I am aware it's 2 o'clock, so we're going to go ahead and get started. Welcome to Project Echo Flourish Connect, our collaboration between the University of Louisville and the University of North Carolina. We are so happy you're here today. So this is just kind of a reminder of some of the curriculum over the next 24 weeks. We are in week 2, focusing on age-friendly and trauma-informed systems. But you'll see that we're going to be covering a lot of information over the next 24 weeks. And so we're so glad that you are joining us. A few technology tips. Most people are probably pretty acclimated to Zoom by now. As a reminder, if you're ever in the large group and there's some background noise, I might mute you, but you're always welcome if we're asking for questions or for feedback to please unmute yourself and turn your camera on if possible. Dr. Cotton also has some suggestions if you're on a phone regarding how you can get unmuted. Sam?
Yeah, so if you're calling in on your telephone, in order to unmute on Zoom, you actually have to hit *6. Just unmuting your microphone doesn't always work. So just remember that if you have anything you want to say, comments, questions, anything like that, *6 is the magic number to get you unmuted.
Thank you. And so many people have already started putting their names in the chat. That's really helpful. It helps us take attendance. So if you could put your name in the chat, and if you're in a room with multiple participants, if you could do that now, that would be really helpful. You can also change your name by clicking on the 3 little dots in the upper right-hand corner. There should be 3 little dots in the upper right-hand corner of your Hollywood square. If you click those 3 dots, it'll drop down and there'll be an option to rename yourself. So please do that. So I am going to also ask my teammates to introduce themselves. Again, I'm Justin Magnuson. I am a Project Echo program manager here at the University of Louisville. Dr. Sam Cotton, would you like to introduce yourself?
Yeah, hey everyone, it's Sam Cotton again, and I'll be presenting our topic today. So you're going to hear a lot more from me.
Thank you. And Dr. Chris Henage.
Hey, glad to be back with you. Thanks for the shout out for all the curling fans out there too. Hope you're finding some time to enjoy things like the Olympics or something, you know, not work focused, looking for that balance as a way to, I don't know, mitigate my own stress. Thanks for being here.
I appreciate that, Chris. Dr. Ellen Roberts.
Yes, hi. Great to be with you all. Ellen Roberts from the University of North Carolina School of Medicine, and part of the team is working on the evaluation aspects. So just kind of want to remind you, which we'll do at the end, to everyone, whether you're getting continuing education credits or not, to fill out the survey at the very end, because that's important to us for feedback as well as for those of you who are getting continuing education.
Thank you, Ellen. And Dr. Emily Citrone.
Hi, I'm Emily Citrone. I'm a geriatrician with UNC. Nice to be here with everybody. Thank you.
Appreciate everybody being here today. Sam, if you can advance the slide, please. So again, as Ellen mentioned, please, completing your survey at the end really helps us with our funding and helps us keep track of who's here. And it's also required for continuing education, but we really are asking everyone to please complete a survey at the end of today's session. And this is our attestation from our continuing education provider, again, providing CEs for nurse practitioners, nurses, and nursing home administrators. And today's presenter has nothing to disclose.
All right, and I think we're back to me, right?
Yes.
Okay, and as Justin said, I have nothing to disclose except that I have a passion for age-friendly and trauma-informed care, and how we can best help our residents through some of the trying times that we've all had as it relates to COVID and other things that are just in general going on in their lives. So today we're going to be focusing on plan of care and how to, take these concepts and really focus in on, assess what's going on with residents and apply them in a way that's beneficial, and also in some respects would help alleviate staff and caregiver burden within your nursing facilities. So as last week, we did the same thing, the same format. So we're going to have the didactic, then we're going to have a case presentation, large group discussion, and then we're going to have recommendations as it relates to the case that I'm going to present. We're also going to share with you how you can share cases for next week and subsequent weeks as well, and walk you through that process if you have any questions. So looking forward to going over all of this today. So again, I just want to highlight that our hope for this session and this whole Project ECHO for that matter is really to develop community among all of you, to really have that opportunity to share and learn from each other. And so if there's anything that either I'm talking about that you have questions about, or that you have thoughts about, or suggestions for the team, things that your nursing facility has tried, let us know. Jump in, unmute yourself, or put it in the chat, because we really want to engage with each other. If you can turn on your camera, please do, because it helps us to all be able to see each other. And then if you're not able to unmute yourself or something of that sort, you can definitely put comments in the chat as well. We're going to be monitoring those and giving some shout outs to what you all are saying there. And then if you're having to call in, just a reminder for those of you who may not have heard this at the beginning, who are phoning in, who are not on your phone or not on your computers, you can hit *6 to unmute yourself. Just unmuting yourself on your device doesn't always work with Zoom. You have to hit that *6 feature. And as I mentioned earlier, today we're going to be talking again about age-friendly healthcare and how to develop plans of care that focus in on those domains. And then we're going to apply the basic principles of trauma-informed care to plans of care as well. So before we get started with that, actually, I'm going to skip ahead here real quick. Does anybody remember from last week? Many of you mentioned that the 4 M's of age-friendly healthcare in our session, that you were new to those. Can anybody remind us what those are, what the 4 M's are? You can put it in the chat, or you can unmute yourself. I was saying earlier this morning, we need some Jeopardy music to go along with this part. Anybody wants to hum that for me? It'd be great. So Lisa, you said mobility in the chat. Yes, mobility is one of them. Okay, mentation. What matters most? Mentation, medication, and mobility. Woo! We have a winner over here. If we were in person, I would toss out some prizes to you all, but unfortunately we're stuck in 2D world for now. But yes, so the 4 M's of age-friendly healthcare are what matters most. Obviously, that's going to be our starting point in terms of our conversation with our residents, in terms of figuring out, what's important to them, what brings them joy in some respects. We want to focus on mentation. We want to focus on medication. We want to focus on mobility. Again, all very important in terms of thinking about resident care. So what about trauma-informed care? Can anybody explain to me what that is? Either the 4 R's, but in general, if you'd rather just say, what trauma-informed care means to you, that's fine as well. And I know a lot of you mentioned last week that you were familiar with trauma-informed care and were, working towards using those best practices at your nursing facility. So it'll be good to hear from you all. Realization, recognizing, responding, and resisting. Yes, Kathy, thank you. So yes, we want to make sure that we have that as an organization, and then also individually as professionals, that realization that trauma is something that impacts individuals, that it affects everybody in different ways. Recognizing what those effects are, what those triggers are for the individual, having systems in place so that we can respond to those traumatic events that individuals have dealt with, and make plans. So this is where the plan of care is super important, to best figure out how you can help the individual in those moments. And then resisting re-traumatization. And why that part's so important too is because sometimes even small situations that remind a person of the event, the stressful event that happened in their life, can re-traumatize them. So they're being subjected to that over and over again. And that can be problematic for their overall mental health, for their overall well-being, and cause, undue stress. So we want to help individuals not be re-traumatized over and over again. So thank you all for jumping in and sharing those answers with us today. And good to know that, you all were paying attention last week. So really the idea between, and I said this last week, and I'm going to say it again, so I probably am going to sound like a little bit like a broken record or related to this piece, but we really want to create that culture of compassion in our nursing facilities and be deliberate and intentional about putting in place some of these measures so that we can really help our residents. Sometimes, and I know that we all have these situations in our nursing facilities where we have some residents who are particularly difficult or have challenging behaviors that become difficult for staff to deal with and to respond to. And so really making sure that we put these measures in place can help alleviate some of that stress, right? Because of COVID, we've all been, under undue stress due to everything we're dealing with related to the pandemic. And so these types of best practices and implementing them consistently within our nursing facilities can be so helpful in terms of just making sure that we're not having to deal with extra stress on top of everything else. So traditionally, plan of care for residents, when we're doing those at nursing facilities, they can be very much focused on a number of different areas. A lot of times we do talk about person-centered language when we're developing them, but the content might sometimes be more focused on helping them with activities of daily living, things like dressing, eating, bathing, what are those things that the individuals need in terms of just getting through the day-to-day, right? So what we would call probably more basic nursing care focused. And those are all really important things, right? In terms of helping residents with, but sometimes we add another layer onto this to really help in terms of resident engagement, just quality of life, kind of more measures for the individual to be focused on. And then sometimes in terms of plan of cares, we're focused more on those end of life care situations. So those shifting kind of things that can sometimes happen with an individual where we're transitioning from maybe we're more focused on what do they need to have that quality life at the end. So traditionally, when we talk about plans of care, this is what we're talking about. And sometimes we maybe align them with our internal values and mission as well, but overall more focused on that person-centered, what does that look like for that particular resident in terms of their day-to-day. However, sometimes it's good to step back and look at how can we focus in on these different domains to make our plans of care more age-friendly and focused on how do we create systems within our nursing facility to accommodate some of these needs. Because for some residents, screening for medication, for example, on a regular basis and making sure that we're having regular pharmacy reviews, that's not going to be just helpful for one person in your nursing facility. That's a, more system-wide thing that you can do. And next week, we talk about age-friendly and trauma-informed care. So we're going to talk more about that culture in our nursing facilities and how to facilitate that as well. So stay tuned for more content in that particular area. But in general, today we're going to focus on the 4 domains for age-friendly. So of course, as we mentioned last week, we really want to anchor our plan of care into what matters most to the resident. And sometimes you can ask questions of your residents to kind of get at the what matters most piece. And we kind of explored that a little bit last week. But these questions are really that I have listed here. And obviously we're going to share this PowerPoint with you. So don't feel like you have to write all of this down. But these questions are really supposed to help you get oriented in terms of how do I present this to the resident so I can better understand what's important to them. And of course, every person's what matters most is going to be different for them. Some people are going to be more focused on those health care goals. Some people are going to be more focused on the social aspects of their life. Some people are going to be more focused on what they don't want, because maybe that's an easier thing for them to identify in their life, that they don't want to do a certain activity or participate in a certain thing. Does anybody, and you can unmute yourself or sound off in the chat, does anybody have other ideas for how we could really anchor our goals for plans of care surrounding what matters most to the person? We had somebody this morning who shared that at their nursing facility, they actually were able to do and I can't remember what they called the document. I think it was called Meet the Resident. And so they actually had, before, when a person first came and moved in to their facility, they had a whole document that kind of gave the narrative of who that person was, what they like to do, maybe if they were, what their job was, if they had hobbies. So really helping to better understand that person right from the beginning. And they actually said that they kept that document in that person's room for a long time for reference, so that, you know, new staff could go in and check that out as well as they were getting to know the individual. Morgan, you've got a great comment in the chat. So for those with dementia, getting a good historical background and find out what used to be important, because they might not be able to tell you. Perfect. So I wondered if this question was going to come up, and we talked a little bit about this in the morning session as well. You know, how do you figure out what matters most if a person can't explain it to you, right? Sometimes it's going to be assessing and observing them as you're getting to know them, especially if they don't have family members who are involved. So trying out that smorgasbord of different activities, just to see what seems to, you know, spark their interest. Where do they seem to light up? And I think that that's one of those things that can be super, super important. I see Lisa, you're saying we have a getting to know me form for our dementia unit. Yes, so similar, it sounds like, to what I was asking, or what I was telling you about from somebody shared this morning. We have an all about me card that helps staff take care of people. Great. I think all of these are wonderful suggestions. And if you're not doing something similar at your nursing facility with the persons that are struggling to, you know, really answer those questions that you might have about what matters most, definitely thinking about how can we implement this, you know, whatever approach works best. And also, I think it's important to note that staff communication can be super important in terms of plan, like the what matters most as well, and sharing what you've, especially if a person can tell you that, you know, what they're passionate about, or what they're, you know, what brings them joy, if they've shared that with staff, or staff has had a meaningful moment with them, making sure that, you know, when you have your team meetings or your huddles, that you're having those kind of overlapping conversations so that everyone's on the same page. And then we have one called My Life. Yeah, so it sounds like a lot of you are doing something similar in terms of this piece. So that's great. So what matters most, I think, is one of the really, really important starting points for obvious reasons. But then once we move into our other domains for age friendly, I think that it's one of those important pieces of the puzzle where it's really good for us to start there, but then once we're looking at these other areas, understand that sometimes there's a lot of interconnection, and I'll explain what I mean about that here in a moment. So in terms of mentation, of course, last week we talked a lot about prevention, identification, and treatment of things like dementia, delirium, and depression, like other mental health conditions, like anxiety, or, you know, for our folks who have dementia, sometimes dealing with things like repetitive thoughts and behaviors. All of this can really fall under that piece of the puzzle. And then Morgan, you're making a really good point that sometimes staff and family expect that it's important to the resident to be involved in everything. Yes, so some people, you know, based on personal preference, they might not want to join like all of the various groups that are available to them, right, as part of this. So, you know, always keeping in mind going back to the person and being person-centered with this can be really important. And then a less formal meeting, with resident council, residents activities and plannings where they can help plan. Oh, that sounds like a really great idea to make sure that your programming represents the consensus of what matters most to all of the residents. That's, I think, a really neat concept as well. And probably can also, you know, again, that's still focused on what matters most, but really plays into some of these other areas, right? Because in terms of mentation, you want individuals to stay engaged when they want to, right? So going back to that previous comment, but making sure that individuals are, you know, engaging in things that are meaningful to them and that it's important to them can be a huge component to the mentation piece as well, not just the matters most. So in terms of prevention, and when we're looking at plans of care, you know, we're thinking about kind of individuals who are at different stages in their life. For example, maybe somebody is not having any issues with cognitive impairment. So we're more focused on how can we help them stay in that situation? You know, how do we help them not struggle in some of these other areas, right? As they continue to get older. So looking at things like, you know, incorporating, you know, exercise and movement, nutrition, you know, what are the meal plans looking like for residents? Are the foods nutritious, incorporating fresh fruits and vegetables and other things that we know that can be helpful for overall brain health, right? The social engagement piece, how do we get people to find those activities that they do enjoy, right? So that they're more apt to engage in them. You know, and sometimes that can be even not even just those group activities, but maybe a couple of the residents are getting together to watch a movie or watch TV, and they have a certain show or a certain movie that they're really into. So really focusing in on those areas. Identification. So making sure that we're putting in place routine assessment points. So, you know, how often is the plan of care being revisited with the individual? Are there assessment points where you're looking at things like depression, using the mini cog or rapid cog or something of that sort to assess their cognition, and tracking those changes so you can put plans in place as maybe things change for that individual. And then in terms of treatment, you know, we know that some individuals move to our facilities who, you know, they've already been diagnosed with something like dementia. And so it's how do we then put in those supports to address their evolving and changing needs? How do we make sure that we're focused in on even from when they first moved in to now, if they're struggling with additional behaviors or you're seeing more significant decline, you know, what are some things that from a comfort care or quality care standpoint that you can put in place to really focus in on those areas? I also just wanted to very quickly note that in terms of mentation and transition of care, and we've probably seen a lot of this during COVID as well, where individuals might have to go from the nursing facility to being hospitalized back to the nursing facility. And so I wanted to highlight here within mentation that we do know that dementia is prevalent among our nursing home residents. And for those who have dementia, that is a greater risk factor for developing delirium while they're in the hospital. You have to think you're taking them out of their day-to-day routine, away from, you know, the other resident staff, you know, maybe in some situations during COVID, even their family caregivers who might normally would have been able to come see them in the hospital or stay with them in the hospital were not able to do that. And so really taking them out of that context that they know, right? And sometimes people become disoriented. They can't orient to place and time in the hospital for a number of different reasons. There might be pain or infection that they're dealing with on top of that. So again, things to be aware of, because we know from the current statistics from the CDC right now that 16% of, or around 16% of patients that were discharged to nursing facilities from hospitalizations have unresolved delirium. So they might be coming back home to the nursing facility, still dealing with some of that confusion and disorientation. So you might have to revisit that plan of care that you have in place with them to address those changing needs, even if for the short-term period, right? Until the delirium is resolved. So sometimes creating that structured plan to help them focus on getting the support that they need. And maybe they need more support than they did when they left to go to the hospital. That comfort care that can be helpful to them in that time. And then, orienting them to time and space is very key in those situations. So again, sometimes what we're doing with those plans of care that are age-friendly are, it's a journey where it's evolving, right? And so we want to make sure that even in short-term situations where there's transitions like that, that we're attending to them. Now, in terms of medications, I know we focused a lot last week on polypharmacy, so I'm not going to go down and talk about that in detail today, but, we know that on average, because of the complexities of our residents' needs, that they're on an average of 9 daily medications. And that can sometimes be a lot for individuals, particularly if they're on high risk medications. So things that might be contributing to, fogginess or more like profound cognitive decline, medications that can cause dizziness and put them at risk for falls. So it's recommended that for residents, there are monthly pharmacy reviews in place, especially for those who have been identified to be on some of these high-risk medications. And you really want to do some very deliberate and intentional staff surveillance of changes in mood, behaviors, and other areas, so that you're really focused in on that piece. For mobility, and again, I think I mentioned this with the medication piece as well, that there's some interplay there between the two sometimes. You really want to try and help individuals in terms of thinking through some of those rehabilitative mobility activities that they can engage in, and sometimes making it fun, like incorporating movement into existing programs where, traditionally when we play bingo, we think about sitting. Maybe you do an activity where they're playing bingo, but they're switching from table to table or something of that sort to really help them just stay active and moving. A lot of times we focus on more of the risk in our congregate areas as it relates to falls, but sometimes individuals in their own rooms in the nursing facility can be problematic, especially if they're struggling in terms of, creating clutter or mess that then causes them to trip and fall can be important. Implementing functional assistance when needed. So transfers from one device to another, or from the couch to standing if they need help with that, making sure that everyone's aware of those risks for that particular individual, because we really want to focus in on making sure that people don't fall. And again, just on a note that sometimes these domains are super connected. And so, one plan of care item can touch a number of different points related to the 4Ms. So medication issues, or not having a recent medication review, for example, can cause issues with mobility and mentation if an individual's having multiple falls, because maybe one of the side effects is making them dizzy, maybe one of the side effects of the medication is causing them to be foggy, and you're noticing they're just not themselves. So again, being aware of some of these things is the most important piece. And then that brings us to creating care plans that are trauma informed. And I really want to highlight here that in terms of thinking about trauma informed care plans, that even residents who share the same traumatic event may experience different effects as a result of that. So for your residents who might be struggling with, maybe they're just not naturally open to, having this conversation, and they've not shared this with staff or the individuals working with them, maybe having a special time during the plan of care where you can go over some of these questions and really explore some of these concerns that individuals might have, particularly related to those individuals who you notice maybe have these behaviors that show up in certain situations, and you're trying to better assess and identify what's going on and what caused them to react in that way in that particular situation. So let me give you an example of how individuals can really react in different ways. And the perception of trauma as well can be a profound piece of the puzzle as well. So residents that maybe have experienced car accidents. Now, not everybody who's ever had a car accident feels like that was a traumatic experience for them, but for some individuals that can be. Depending on the situation and what happened as a result. So even if you have two residents that are showing some trauma or triggers related to this, it may present in different ways. One resident might have claustrophobia. They might have difficulty showering, especially if it's like all closed in. They might be triggered by dark spaces. So at nighttime, they get a little worked up and can't sleep, or they're, indicating that they're stressed at night. In addition to that, that could be one experience, but another resident who might have had this similar traumatic experience in their life, they might be triggered more by visual representation. So by movies, media, things like that depict car accidents. So it's important to identify those triggers and center your care plan around those particular concerns. So for the resident who's dealing with claustrophobia, really helping them avoid tight spaces or closed spaces. If showering's the main issue, then making sure that there's a situation where maybe they have a private shower, but it's not completely closed off with a door, like leaving the door open for them can be helpful with staff assistance. Maybe placing a nightlight in the room can be helpful, so that they don't have to have a completely dark space. For the resident who was struggling with the visual representation of, seeing car accidents in movies, offering alternatives on movie night, especially if you're aware of, this is something that's probably going to be in this movie, offering different things that they can watch instead. If a person has been experiencing those situations and really struggling with them, having a plan for use of comforting items to really calm them back down and recenter them. Even things like traditionally we talk about memory boxes, and we don't necessarily have to call it that. We could call it a comfort box. So having something where a person has items that are important to them that they can really pull out, look at. For some individuals, that might be a photo album or something of that sort. Again, focusing on that comfort piece as well. And again, there's a number of different ways that you can focus in on these plan of care items. It's really about being deliberate and intentional of assessing and then figuring out what the individual needs and moving from there to that next, level of care and focusing in on what matters most to that person, being person-centered as it relates to these different areas. So now we're to the case study, right, Justin? Do you want to go over the form piece?
Let's see if there's any questions first or any experiences that people want to talk about, and then we can, I'll introduce you to the case study form and we can move forward.
Yeah, sounds good to me.
Any
And I saw
questions?
some people sharing some stuff in the chat as well as while I was talking. So if you all want to go back and look at that as well, definitely make sure you're paying attention to your peers in there.
So if there aren't
Yeah.
any,
It's Chris.
Yes.
I have a weird question for the community.
Yeah.
I know that we think about nursing home placement for a lot of our families and residents as a loss, but because they're, having to leave their home and so forth. But do we think about that as a trauma? Like, I guess my question is kind of like, where do you draw the line between bad things that happen and considering it a trauma? And some of our older adults don't look through that lens. So I don't know, do any of the nursing home folks have some feedback for me on that? How do we think about placement? Is it something we might consider to be a trauma? And it's a weird question, I know, I just thought of it.
Yeah, I agree with Morgan, what Morgan's putting in the chat too. I really do think it depends on the person.
Yeah, I think it's a really good question though, Chris. I remember I had a nursing home resident who had experienced homelessness intermittently throughout her life. And so for her moving into the nursing home almost felt like she was like back in a homeless shelter. And so, I definitely would
Wow.
consider it for that individual, but it's a really good point. Yeah. And I think generally just that question of like, what is trauma versus not is an interesting one too. And what
don't you think?
Go ahead.
Go ahead. Sorry,
no,
you
I
cut
was
out.
gonna say, I think it relates to sort of our discussion about like, how do we identify triggers and how you, like you were saying, Dr. Klein, about like a certain experience is not, a car accident's not a trauma for everybody in that similar way.
It's perception. It's how we perceive and internalize, and probably that how much of a profound impact it had on us, right? I think it just depends on that situation.
So it's going to be really hard to suss that out. The morning group was asking a question about how do you teach staff, CNAs, housekeepers, dietary folks, frontline folks to recognize the trauma moment. And I had never thought about that before. I thought that was a really great point because it is perception. Dorothy's got a comment. At a CCSC, yeah.
Oh, yeah.
I never thought of that, Dorothy. Just changing, well, yeah, changing levels is.
Yeah, it's different. It's a different, you're moving from one space that you maybe are familiar with to a different area where you're not so familiar with everything. Also, maybe those losses, those continuous losses that people have, that the grief, that they don't necessarily always know how to talk about as well with transitioning.
Yeah, out of curiosity, Dorothy, do you have any like extra supports that you try to put around people as they're changing levels? Hylian has a comment on that. Reminiscence, Dorothy says. Yeah, avoid, yeah. Hylian, Sam, can you speak to what Hylian is saying in there? And I hope I'm saying your name right.
Patients now, we same time respect patients' privacy. Yeah, so I agree. I think it is very difficult in these situations, right? Because you don't want to just sometimes it's difficult, right? Because we work in open congregate settings. And so you've got staff who are trying to communicate with each other as well to let each other know about what's going on with the resident. But you also don't want to see if, you don't want to see somebody's trauma get re-traumatized because that situation's not getting ignored, right? So you don't want that perpetual cycle to continue. So sometimes it's about finding that balance of, figuring out when are we going to have these conversations so that they're not just in front of everybody. And then the other thing I would like to add too is that I think that a lot of times people don't use the word trauma in some of our different generations. Like that's a more of a newer way of talking about some of those stressful events that have happened in our lives. And so sometimes framing it in that way when you're talking, like what were those events that happened in your life that contributed to stress, can be a better way to frame that conversation. And then the third thing I want to say is that sometimes, especially with our persons with dementia, they're not always going to be able to communicate to you with it, or communicate to you about that situation. You might see that in certain contextual situations that they're acting out or having challenging behaviors, and it could be related to that trauma that they've experienced, but they don't know how to tell you, this happened to me when I was 12, right? So that's a whole thing. I do want to highlight that in those situations, having, the caregiver or the family member involvement can be helpful, but we know that's not always the case for all of our residents. So sometimes it's going to be that kind of observing and focusing more on the emotion in that situation and try to prevent that cycle from continuing to happen. And even if you don't know what triggered the like what was the traumatic event to avoid it. Sometimes you can infer based on how the individual's reacting contextually in different situations that, ooh, this is not a good scenario for them to be in, so let's avoid that. I hope that's helpful.
So I put in the chat basically a link to this document. So moving forward, what we're really hoping is that you'll be providing case examples so you can present and get feedback regarding those cases. But what I put in the chat is when you answer the survey, basically it'll produce a document like this that will allow you to put the first and last name of basically the person that will be presenting and their role and their email address, and whether or not you will be interested in presenting. But basically, if you're not interested in presenting, we can present the case for you. But we'll have 5 to 7 minutes for people to present a case. And what you see here is basically just a real simple format for assessing the 4 M's and trauma-informed care to really help shape your key questions and the things that you're possibly struggling with or need some feedback on. So Sam, do you want to present the case example today, and then we can have our discussion?
Yes, I can definitely do that. So as you can see here, you can put as much information as you need to put. You can also, for some individuals, now this particular resident, there was information that kind of hit all of the different boxes, but you don't have to fill out a section if you don't have any need for recommendations in that particular area. So let's say the person didn't have any mobility issues that you can speak to, that's okay. You can just leave that one blank, for example. So with this particular case today, I want to highlight a couple of things. One, the resident has really been struggling with behaviors, sudden onset of these behaviors within the last 6 months. Prior to this, had not really had aggressive or agitated outbursts. In the past, she really enjoyed hanging out with some of her friends at the facility as well. Very social, very much involved in all of the different groups. She also likes to knit as well, and around the holidays would always knit different items like hats and scarves for some of the other residents. And lately, she's not shown interest in these activities anymore. Very depressed, very withdrawn. Related to mentation, because she was exhibiting some depression, her doctor started her on new medications to address some of those issues. And so now she's taking sertraline, and so that's a brand new medication for her. In terms of, I think I flip-flopped mentation and medication, but she is depressed, so I'll skip over that part on this piece. But she's also becoming more and more withdrawn as well. And then again, just to mention those aggressive outbursts that she's dealing with. In terms of mobility, she's fallen 3 or 4 times in the last 2 months. And staff overheard her telling her roommate that she was feeling really dizzy prior to one of the falls. But when the staff asked her about it, she said, oh, no, I'm fine. So really not disposing that to staff, but did overhear her telling that to her roommate. And then in terms of trauma, no one's really aware of maybe trauma that happened in her past. However, she has seemed to really struggle during some of the traumatic events related to COVID, more so than some of the other residents in the facility. And anytime there's been a lockdown or move of residents around, the shuffle that had to happen in some situations so that people could isolate with COVID, that was really a struggle for her. And she also had a couple of friends that she was close to who passed away from COVID. So this has been a very profound kind of thing in her life, as I think a lot of us could relate to. So I was wondering, do we have recommendations for this case? Justin, you could actually take us back to the squares, Hollywood Squares, so we can see everybody. But any feedback, suggestions on how to proceed with working with this particular resident? And I think, part of the staff concern here is the combativeness that they're seeing, the agitation that they're seeing with her. So Dorothy's got a recommendation for us. Evaluate new medication that could be contributing to falls. Yeah, so is the new medication that she's on causing some of that dizziness, which is then in turn contributing to the falls? What other medications is she on as well? You know, we focus more on the new one, but there could be other things as well. Medications related to falls and dizziness, yes. Anything else medically going on? Check orthostatic. So is she doing what's her blood pressure? Is she having some issues from sitting to standing? Good cognitive assessment. Maybe she's no longer doing knitting because it's too difficult. Yeah. And she doesn't want anyone to know that. UTI, eye exam. These are some great recommendations. Therapy eval. I think the therapy piece might be helpful for her, given some of the grief and loss that she's had. Maybe even some art therapy if she's not able to talk through some of those different issues that she's struggling with. Anything changed with the family interaction? That's something probably to assess. We don't know based on what we have for today's case, but maybe something, you know, that's been challenging for her. She's missing that personal connection. Social support, I think a comprehensive assessment to kind of better understand some of these behaviors can be really important as well, because think about some of those, the changes coming on seemingly rapidly, right? Within the last 6 months, when she'd never had anything like that before. Yeah, these are all really great. I do want to clarify something. When we had the case study pulled up, you saw the form. I want to make sure that when you all are filling that out, that you're aware that when it says first name and last name, we're not referring to the resident. We're talking about you, the person filling out the form. And that's so we can reach back out to you as well and follow up and ask, some questions or see how we can support you with some of these cases. So make sure when you're filling out these forms, you don't have to put any identifying information about the resident in there. It can all be very general, which is what I had. And we can even, if you're uncomfortable with having your name pulled up when we present the case, we can definitely blur that out like I did for the one today. So Justin, how are we doing on time?
A few more minutes. If anyone has any questions or comments, or maybe a few minutes to talk about something similar, or but yeah, we have some time.
Yeah. Does anybody have or Chris, you have something, it seems, maybe.
Well, I'm thinking, Sam, this was your case. Can you tell us kind of what happened in the end? Did things get better? What worked?
She actually did have a UTI. And so
Morgan said that.
Yeah, so really struggling. Happened. Obviously the infection lingered a while for her until it got resolved, because it was not something, she wasn't expressing pain. It was more of the behaviors were the first kind of tip. And I would say that she's still not 100% back to that, but I think some of that has to do with some of the things related to COVID. But art therapy was something that we're actually about to implement with her. We're hoping that helps, because she's a very private person. And so very much doesn't like to express herself to new people, I guess is the way I'm going with this. So doing some rapport building with some art therapy students.
Nice. Thanks for the update.
Yeah. Now, this morning we had some folks share with us that they're really struggling with some of the new reporting mechanisms that you have to do at your nursing facilities, especially related to the vaccine, who's fully vaccinated and all of that. Is anybody else struggling with that or need some feedback that you would like from the group? Or there could be other things, to Chris's point, that you've got going on that you need some, even if we're just commiserating together, it's a good opportunity for that. No, we're all good. No one needs to share. Okay, well, we'll turn it back over to Justin then.
Sorry, my computer is functioning very slowly. Okay, and I don't know why it's looking like that. Thank you for the conversation. So basically, I will be following up with, after today's session, with Sam's PowerPoints and the case summary link and the survey link as well. But I'm going to go ahead and ask you to, I'm going to put it in the chat. And we're really going to need everybody to complete this session evaluation. And Ellen, do you want to talk a little bit about the session evaluation and why this is so important?
Yes, thank you all so very much for all of your input, feedback, and this is just one other way. Unfortunately or fortunately, we do have to report to HRSA your feedback on our sessions and how well this has gone for you. So we would greatly appreciate everyone, whether you're getting continuing education or not, to just point your, if you have a smartphone, to point your phone, the camera at the QR code, and then just fill out the survey. Or if, as Justin said, please put a link in the chat if that's easier. And we thank all of you for taking a few minutes here to just complete this survey for us.
Thank you, Ellen. And so again, as always, if you have questions or comments or feedback, you can always reach out to myself and Jennifer. And if we don't know the answer, we'll be happy to connect you with someone who does. And I hope you'll join us next week. Dr. Chris Henage will present on assessing age-friendly and trauma-informed care in nursing homes.
Yeah, a plug for next week. How do you know if you're actually doing this? I mean, last week we talked about sort of the theories. And then this week, Sam did a really beautiful job showing us where we could maybe apply the 4 M's, the 4 R's. But then next week, we're going to zoom out and look at big picture. How do you know if you've changed your culture to be age-friendly and or trauma-informed? And I'm gonna lean on you all to help me with that, because you're working in the nursing homes and I'm working in the ivory tower in academia here at UNC. So age-friendly, trauma-informed, I knows it when I sees it. How do we know if we're really doing the culture that we've committed to? Looking forward to it, everybody. And please send cases. Please send us some ideas of things that you really need to get some help with, or things that have gone really, really well for you around these issues, or, well, anything else that's top of mind. Thanks.
And Justin, maybe take us back to the slide about the evaluation in case folks didn't get a chance to grab a picture of that or click on the link. And then just to, I know some of you are probably looking at your devices completing this, but I wanted to highlight there was a question about the recording from today. And so it usually takes him an hour or so for it to process. And Justin says he'll make it available as soon as he can. So if you missed some of it and you want to go back and review anything, we will make that available for you.
Okay, well, thank you, everyone. We will see you next week. And again, if you ever have questions, please be in touch.